Here we go.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Often, nurses, physicians, or family members who are concerned that a patient is deteriorating can activate the rapid response system in the hospital. Also, paramedics, using critical thinking skills, can act on signs of clinical deterioration by treating the patient and rapidly transferring the patient to the emergency department. Some rapid response systems weigh, combine, and score specific physiologic criteria to determine when to act. The following list gives examples of such criteria for adult patients. Threatened airway, respiratory rate less than 6 or greater than 30 breaths per minute, heart rate less than 40 or greater than 140 per minute, systolic blood pressure less than 90 millimeters of mercury, symptomatic hypertension, unexpected decrease in level of consciousness, unexplained agitation, seizure, significant decrease in urine output, and subjective concern about the patient.
I hope y'all grabbed all these numbers.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves.
TCI.
Hey, Dr. Buck.
Happy Monday. When you finish with this, I need you to put it off the page down there. I got a whole bunch of promotional items coming in. We got to put them somewhere.
Okay.
Oh,
You all right, Doc?
yeah. Yeah, I'm fine. I think it's that stuff that everybody's got going around.
Good. Acute coronary syndromes, or ACS, may suddenly strike men and women, often after years of asymptomatic coronary atherosclerosis and plaque formation. As plaque forms within the coronary arteries, several clinical syndromes may also develop, with varying degrees of coronary artery occlusion. Two of these syndromes are non-ST segment elevation acute coronary syndromes, or NSTE-ACS, and ST segment elevation myocardial infarction, or STEMI. STEMI is generally considered to be more serious and usually develops after a ruptured plaque or an erosion results in an acute blood clot that significantly or completely occludes a coronary artery. Either of these syndromes can, unfortunately, manifest as sudden cardiac arrest and death. It's estimated that half of the deaths from these syndromes occur outside the hospital, making early recognition and rapid response essential. The best outcomes from ACS occur in communities where programs with strong public education, PAD programs, and STEMI systems of care exist. Watch how emergency medical services and hospital personnel use the STEMI chain of survival to provide a system of care that recognizes and rapidly treats the underlying causes of ACS.
What's going on?
Paycheck's having a heart attack. I'm going to call 911. You get the AED and first aid kit.
Okay.
911, what is your emergency? I think my manager's having a heart attack. I see you're located at 459 Commerce Avenue. Is that correct?
Yes.
Where is the patient? He's right here. He was wobbly on his feet, so we sat him down in the aisle. He's having chest pains and his left arm hurts. Is he awake? Can you talk to him?
Yes, he's awake and able to talk.
I'm going to dispatch paramedics to your location. Stay on the line with me, okay? Don't hang up. I'll have a few more questions to ask you.
Okay.
Any questions? Comments? Concerns? Huh? Who said something? What'd you say?
That smart-ass look on your face.
I had a smart ass look on my face. Any concerns about the STEMI and in STEMI?
So just to clarify, I said the STEMI is caused by the blockage of that plaque buildup in the coronary artery.
It releases troponin from the heart muscle, and that's where you get the ST elevation from, is that it recognizing the troponin. Okay? So, yes.
So if you have no extra elevation,
What a cardiac doctor told me is this: if you have an in-STEMI, you can be having chest pain and you need to treat it, but it's not a total occlusion. It may be like an 89 or 95, but it's not a 100% occlusion. A STEMI is.
okay.
So,
Like you can't tell it on a monitor, you just look in the sensor, right?
no, you tell it on the monitor because in-STEMI is non-ST elevated MI infarction. Okay? In other words, you don't have ST elevation,
Yeah.
but your patient's having chest pain. When you have a STEMI, you have ST elevation myocardial infarction. That means you have the ST elevation on the monitor.
Okay.
But like I said, a doctor told me that an in-STEMI means it's just not a 100% occlusion. It's like 89, 95, whatever, but it's not 100%. When you have ST elevation, it is 100% occluded. Okay, when I had mine, I had ST elevation in 2-3 AVF. In my bottom, they done the right side on me. No, they didn't. The hospital did, because I was having an inferior. The right side was negative, but when they went in, I had an 88% on the right coronary artery and a 99% on the down at the inferior portion of the right coronary artery. So it didn't pick up the right side MI because it wasn't totally occluded. But it picked up the bottom one because it was just about totally occluded. It was 99% blocked. So they put stents in both of them. Questions?
When you put those sticks in, is that for a limited time or for the duration of the life?
Duration of the life, I gotta wear them. So what they do is they go in under high pressure and blow that balloon up and stretch out the vessel. Once they stretch that vessel out, then they go in with that stent, which is like the inside of a hose. You see that string stuff on the inside of a water hose, but it's made of metal. And they put a certain amount of pressure on it, so when they let off, that metal stays and keeps that vessel open. I got 3 of them, because they went back like 3 years later and had to put another one in.
They don't never like discharge or anything like that?
No, under the amount of pressure they put them under, no. And I got cards in my pocket I have to carry, that tell the amount of pressure, where they're at, all of that. But I've had ever since I started taking grapeseed extract, which the doctor in Duke told my uncle to do that. And after 3 years, yes. Huh? Wait. And it told my uncle to take grapeseed extract. They went back 3 years later and done a cath on him. Now, he had triple bypass. But they went back and done a cath on him, and his vessels was 100% open. So I've been on the grapeseed extract, and they went like 2 years ago, they went in me again because I was having chest pain while I was on the river. And when I finally got to the hospital the next day, they done a cath on me, and I was clear as a bell. He said all my stents was clear, all my vessels was clear, nothing had changed. So, and that was just by taking grapeseed extract, and I take it every single day. All right.
The first step in the ACS algorithm involves the patient, bystanders, and medical personnel recognizing the warning signs of cardiac ischemia.
We all had basic first aid training and CPR training about 6 months ago, and when Jack said his chest was hurting and his left arm was hurting, that's when the alarm bells went off for me.
Our system uses priority dispatching protocols, which help identify the problem and determine what type of response to send. What the caller described fit the protocol for ACS, which required a high priority EMS response.
While waiting for EMS to arrive, dispatchers may advise patients to chew 162 to 325 milligrams of non-enteric coated aspirin. This recommendation should be in line with approved medical protocols, and only if the patient has no history of true aspirin allergy or gastrointestinal bleeding.
Okay, paramedics are on their way. Stay on the line with me until they arrive.
Do you have a first aid kit with you?
Yes, and I have our AED too.
Great. Is the patient still conscious?
Yes, he is.
Okay, then we won't need to use the AED right now. Ask if he has an aspirin allergy or any recent bleeding from his stomach.
Jack, do you have an allergy to aspirin?
No,
Have you had any bleeding in your stomach recently?
no, I don't think so, no.
Notable questions.
Look at the first aid kit. If it has aspirin, have him chew 2 to 4 baby aspirins or 1 adult aspirin while you wait for the paramedics to arrive.
That brings us to the next step in the ACS algorithm: assessment, care, and hospital preparation.
What happened?
He's been having chest pains for about 10 minutes, and the 911 operator said to give him an adult aspirin to chew.
Sir, how you feeling?
Not so good. It's my chest. I feel like somebody's squeezing it.
Okay. Well, we're gonna help you out, reduce that pain. I'm gonna get 12 leads. Go ahead and get his blood pressure and put him on pulse ox. When we arrive on scene, the clock is ticking. I know I've got to assess, but if he doesn't need immediate resuscitation, my highest priority is to obtain a 12-lead ECG, manage the symptoms, initiate transport as soon as possible. Every minute matters. The longer it takes to get to the hospital, the poor the outcome for the patient. In fact, half the people who die from ACS are dead before they even reach the hospital. So I follow the ACS algorithm closely just to make sure that doesn't happen.
Administer supplementary oxygen if the patient's oxygen saturation value is less than 90%. Give aspirin if the patient hasn't taken any yet and there are no contraindications. It's critical that out-of-hospital healthcare providers obtain a 12-lead electrocardiogram.
So you're skimming.
This early ECG helps classify patients suspected of having an ACS into 2 groups based on ST segment deviation before they reach the hospital. It's preferred that patients with ST segment elevation be driven, if feasible, to a hospital that performs primary PCI. This initial ECG speeds the patient's diagnosis and shortens the time to reperfusion.
Recognizing ST segment elevation on a 12-lead ECG takes training and practice because different thresholds exist for patients depending on their age and gender.
If a STEMI is suspected, EMS should notify the hospital or transmit the ECG for interpretation.
Question. Now, what's the highest priority when you get on that scene that patient is not in cardiac arrest? 12 lead. Very good. State of North Carolina says you should have one if that patient's not in cardiac arrest within 5 minutes of arrival.
The patient had ongoing symptoms of ischemia, so we administered nitroglycerin sprays every 3 to 5 minutes for a total of 2 doses, 3 to max. We monitored the patient's blood pressure in each dose.
Before giving nitrates in any form, make sure there are no contraindications, such as severe bradycardia, tachycardia, or hypertension. Also, confirm that the patient hasn't taken any phosphodiesterase inhibitors for erectile dysfunction in the past 24 to 48 hours. Patients with inferior wall STEMI on their 12-lead ECG can often have right ventricular involvement. This can be confirmed by a right-sided 12-lead. If RV infarction is present or suspected, nitrates in all forms are contraindicated. Clinically, it may be suspected in patients with hypotension, clear lungs, and elevated JVD. If the patient receives nitroglycerin but does not experience pain relief, healthcare providers can consider giving analgesics, such as morphine, while monitoring the patient's blood pressure and respiratory rate. Use morphine with caution for patients with unstable angina.
County Medical, this is Rescue 1. We've got a STEMI alert. 46-year-old male, chest discomfort started half an hour ago. The current vital signs are BP 104/78 with a heart rate of 96, pulse ox 95%. He was chewed 325 milligrams of aspirin and received 2 rounds of nitroglycerin sprays, but still says he has chest discomfort. 12 lead shows ST segment elevation of 3 to 4 millimeters and leads V1 through V4. ETA to your facility is 10 minutes.
Rescue 1, we received your 12 lead in your initial report. We'll activate our heart alert system, contact the cardiologist and cardiac cath team. Getting this advance notice really helps us speed treatment of these patients, increasing their chance of survival. We can have a cath lab prepped and ready by the time the patient hits the doors of the ED.
The American Heart Association recommends that EMS personnel transport patients who have a STEMI to the closest appropriate facility that provides reperfusion without delay. Based on hospital local protocol and cath lab team being prepped and in place, it is best practice to bypass the ED and take the patient straight to the cath lab where initial evaluation can take place.
Studies show that ED evaluations are responsible for as much as 33% of the total time from symptom onset to treatment. We try to reduce delays by having everything ready when the medics arrive. After seeing a 12 lead the medics had sent, I immediately activated the PCI team and alerted the cardiologist.
When the patient arrives at the ED, we move to the next step in the ACLS algorithm. Reperfusion goals for STEMI patients include PCI within 90 minutes after the first medical contact, or fibrinolytics within 30 minutes from ED arrival. The appropriate therapy is defined by patient and center criteria. Within the first 10 minutes after arrival, staff should provide an immediate assessment of the patient. That includes taking vital signs, getting a brief, targeted medical history, completing a fibrinolytic checklist, and obtaining blood studies. If the early ECG shows no signs of ST segment elevation, then a repeat ECG in the ED is warranted. The staff should also get a chest x-ray within the first 30 minutes after arrival. In addition, draw a STEMI panel. Adjunctive treatments include unfractionated or low molecular weight heparin, bivalirudin, P2Y12 inhibitors, IV nitroglycerin, beta blockers, and glycoprotein 2B3A inhibitors.
Hi, Dr. Taylor.
Hi, how is he? Did he have a heart attack?
I'm afraid so.
but his vitals are improving.
Dr. Abrams is an excellent cardiologist. He'll be going over the next steps. He'll be a good mentor. Okay?
This patient presented with ST segment elevation of 3 to 4 millimeters and leads V1 through V4. Now, this suggests that his LAD artery is occluded. Immediately opening up the artery with PCI and restoring normal blood flow is my primary goal.
The final link in the STEMI chain of survival is treatment. The preferred reperfusion strategy for STEMI patients is PCI.
Hi, Ms. Brennan, I'm Dr. Abrams, your cardiologist. How you doing?
Not so good.
Well, hopefully you'll be doing a lot better soon. I just want to talk to you a little bit about what's going on. I reviewed your ECG, and it appears you have a blockage in one of the arteries to your heart. Now, to open the artery, we need to perform a procedure called PCI that will help reestablish blood flow to your heart. Basically, we insert a catheter into the artery with the blockage and inflate a balloon to widen the block area. We then place a stent to keep the artery open. And the sooner we can do this procedure, the less damage may be done to your heart. Okay?
Okay. I understand. I'm ready.
All right. Let's see what we can do to help you do that. Okay?
All right.
Question.
PCI within 90 minutes, fibrinolytics within 30 minutes, and chest rate within 30 minutes.
Yep.
Anything else?
Nope. Just make sure you do the thrombolytic checklist. And you know we carry labetalol and sodalol for hypertension. Okay? There are facilities or medics that carry those. Alright? Beta blockers do good during the MI because they regulate. Now you can't give it to them if they're hypotensive, but it regulates how the heart works by decreasing oxygen demand by slowing the heart rate down. Okay? So if you hear that, you'll know what they're talking about. Okay?
PCI opens the blocked artery with a tiny balloon. Then a stent or metal scaffold is inserted to maintain blood flow to the heart. When choosing between this reperfusion strategy and fibrinolytic therapy, hospital personnel must consider a number of factors. Studies show that treatment delays increase mortality in both groups, regardless of the reperfusion strategy chosen, but were more pronounced among those patients receiving fibrinolytic drugs. In these cases, the more time that goes by, the more heart muscle is lost. The better EMS systems and medical centers work together and the faster they can deliver treatment, the more heart muscle and patients can be saved.
We had a great outcome with that patient, but we wouldn't have if every link in the chain hadn't been working cohesively.
All the pieces fit together perfectly, and it all began with a call from his coworker. The dispatcher assisted in the administration of aspirin prior to our arrival. We were able to get to him in time, identify a STEMI, and move him quickly to a hospital where they were ready to do PCI. He's back at work today because of it.
Yeah. Questions about that? PCI. Now, I do know sometimes they don't like to play the game like it's supposed to be played at the ER with the doctors. But you know what MD stands for, okay? My decision. Huh? What did you say? Metrodome. What? I ain't never heard it. Just tell me.
No,
Okay. Huh? What is it? Tell me. I want to be in it.
You say methadone?
I want to hear it. What is it? No.
You said the MD said, I just said MD said methadone.
Okay. Well, there's nothing wrong with that. Why don't you share it?
Well, how is that what they call him that? You like, no, that's about
Not me, honey. There's one thing I believe in. They put their pants on just like I do. I put my pants on just like you do. That's why I don't talk down to you or anybody in this class. Okay? I'm not picking at you, but I don't talk down to you. Well, maybe some of them. Anyway, I know doctors don't like to play the game, but I like to see doctors get their ass reamed by the cardiologist when he comes down and looks at it and tells that doctor from the ER that, nah, we're going over here. Especially at Cape Fear. I brought one in there. New onset left bundle branch block. And this guy was fresh out of the military, so he was fit. And I carried him in there, and he started with a new onset left bundle branch block, then started getting elevation in his 12 lead with the concordance. And I rolled him in there. The doctor's like, wait a minute, wait. You know, you go to the left, go to the cardiac. When you go in the ER. And we started to go to the cardiac side, and the doctor was like, wait. Let me see that 12 lead. Well, he looked at it a minute like, nah, this ain't nothing. About that time, the cardiologist walked down and looked at that 12 lead and said, you can't see that elevation? Carry him to room 1. Right there in front of me, I was like, you got your shit. So, you know, it takes everybody playing the game, all right? You can't leave it all up to the pitcher. Everybody's got to play the game. Any questions? Comments? We might not have to do CPR. They might have pulled it out. We'll see. Stroke. Stroking from the east. Stroking from the west.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves.
What was all that about?
Stroke is a leading cause of death and the #1 cause of disability among adults in the United States. We're going to demonstrate how to quickly recognize the telltale symptoms of acute ischemic stroke and model how to respond promptly and get appropriate care and treatment. First, let's review the pathophysiology. A stroke occurs when blood flow to the brain is interrupted, either by a clot, called an ischemic stroke, or when a blood vessel ruptures, called a hemorrhagic stroke. 87% of all strokes in the United States are ischemic. This type of stroke occurs when plaque due to atherosclerosis collects along the walls of the arteries, narrowing the arteries leading to or lying within the brain. As in the coronary arteries, disruption of the vessel wall can cause a clot to form, further narrowing or even occluding the artery. Pieces of clot can break off and travel deeper into the arteries, and eventually lodge in a smaller vessel in the brain and cause a stroke there. This interruption in blood flow ceases function in the affected brain tissue, leading to a sudden onset of symptoms. Brain injury can be minimized and fatalities can be avoided when family members and healthcare providers use the stroke algorithm and follow both the stroke chain of survival and the 8 Ds of stroke care. When a stroke occurs, the stroke chain of survival suggests the following actions: rapid recognition and reaction to stroke warning signs, rapid EMS dispatch, rapid EMS system transport and pre-arrival notification to the receiving hospital, and rapid diagnosis and treatment in the hospital. The 8 Ds of stroke care act in coordination with the chain of survival. As our case study reveals, it's essential that family and healthcare providers follow these steps and work together to rapidly recognize and treat acute ischemic stroke. As you'll see, time is brain. Because many strokes occur at home, it's essential that family members recognize the signs of a stroke and promptly call for help.
It all happened so quickly. One minute she was fine, and the next minute she just fell over. Ellie, honey, what's wrong? Talk to me. It's okay. I'll call 911. Something's wrong. Her mouth was dripping. She couldn't speak. The whole right side of her body just went limp. Immediately I called 911.
As you can see, the first crucial step in the stroke chain of survival is activating the emergency response system. This is also the first D in the 8 Ds of stroke care: detection of symptoms.
Questions, comments, concerns?
Rescue 21, respond. 3326 Davis Lane, possible CVA.
Rescue 21, copy.
You're responding to a 45-year-old female with notable weakness to the right side and facial droop.
The second link in the stroke chain of survival is rapid EMS dispatch. This is also the second D in the 8 Ds of stroke care.
Strokes receive a high dispatch priority, and we try to get there as quickly as possible. Part of the reason to get to them quickly is in case there's a life-threatening problem, but another part is to get them to a stroke hospital where fibrinolytic treatment can be administered and possibly reverse the damage.
They're here.
Hi, Mrs. Vega. We're going to help you out. Eddie's going to take your vitals, and I'm going to ask a few questions.
Well, the first thing I want to do is rule out any other possible causes for the patient's condition. I discovered Mrs. Vega wasn't experiencing any chest or back pain, and she wasn't having any trouble breathing. Mr. Vega also informed us that she didn't have any history of diabetes or seizures. To rule out hypoglycemia, we did a quick finger stick blood glucose analysis. It was fine. I also confirmed she's on any blood thinners.
EMS should also test the neurologic condition of the patient with a stroke assessment, such as the Cincinnati Pre-Hospital Stroke Score.
Mrs. Vega, can you smile for me? Okay, Mrs. Vega. Try to close your eyes. I want you to hold your hands out front. Okay. Mrs. Vega, I want you to repeat something for me. Can you say, "You can't teach an old dog new tricks"?
You can't teach dog.
The stroke test definitely showed key abnormal indicators, strong signs of a possible stroke. And Mr. Vega informed us that the symptoms had started 20 minutes before we arrived. I knew I had to make decisions quickly.
To help identify which hospital is most appropriate for the stroke patient, EMS should also perform a severity score to indicate if there is a possible large vessel occlusion. As always, EMS should follow local stroke protocols.
What are her vitals?
Blood pressure is 190 to 110, heart rate is 110, respirations are at 14, her pulse ox is 95.
Her blood pressure was elevated, but her oxygen saturation was normal.
Mr. Vega, we think your wife is having a stroke. We'll need you to come with us to County Medical. They're specially equipped to handle the situation. The sooner we get there, the better.
Happened so fast. The EMS team had her checked out in 10 minutes. And they even let me ride in the back, keep her calm, answer your question.
The third link in the stroke chain of survival is rapid EMS transport to a hospital that is equipped to deal with acute stroke. This is also the third D of the 8 Ds of stroke care, delivery of the patient by rapid EMS transport.
Rescue 21, go ahead.
We are en route with a possible stroke patient, a 45-year-old female with weakness on right side, facial droop on right side, and difficulty speaking.
While we were en route to the stroke center, I radioed ahead so that a stroke team could be fully prepared once we arrived.
Patient's blood pressure is 190 over 110. Her heart rate is 110, and her respiratory rate is 14 without difficulty breathing. Patient's blood glucose level and pulse oximetry readings are within normal limits. The patient's ECG shows sinus tachycardia without ectopy, and according to family members, the first onset of symptoms was approximately 23 minutes ago, 11 a.m., and we have an estimated time of arrival of 5 minutes.
Received Rescue 21. We'll be ready. Let's activate our stroke team.
Questions? Y'all have to use females, you have to use the bathroom upstairs now. The one downstairs flooded. I reckon somebody couldn't hold their feet. Huh? Huh? Jordan, were you in there? Hey, I go in there. I made a mistake when
There
there
is a
before.
limited window of opportunity to evaluate the patient and determine eligibility for
I went in there one time and seen it was all stalled.
Getting that
I said,
advanced
I'm in
nurse
the wrong
review
bathroom.
allows me to notify the stroke team so that they're poised to respond when that patient arrives.
The fourth D of stroke care is DOOR. DOOR stands for the effective triage of the patient. The initial evaluation should include assessment of the patient's ABCs, airway, breathing, and circulation. Hospital personnel should administer oxygen if the patient becomes hypoxemic while en route. It is best practice to bypass the ED and take the patient straight to the CT or MRI suite. Hospital personnel should assess a patient with a suspected stroke within 10 minutes after the patient's arrival in the ED, CT suite, or MRI suite. Follow your local protocol. Confirm IV patency and draw blood samples for blood glucose, electrolyte, CBC, and coagulation studies. Even though EMS did a finger-stick blood glucose analysis, hospital personnel should review and verify blood glucose results. Hospital personnel should also acquire a 12-lead ECG, which may identify recent myocardial infarction or arrhythmia as a potential cause of the stroke. The next step in the 8 Ds of stroke care involves the collection of data, ideally within the first 20 minutes of a suspected stroke patient's arrival.
I get her history, perform a general physical examination, a neurologic examination, and establish the time of symptom onset. In this case, the first symptoms were about 45 minutes before. After asking a few questions and performing the NIH stroke scale, there were pretty clear indicators of a stroke. Since EMS had called ahead on their way to us, we already had our neurologist standing by.
Now, you have to remember the clock is ticking. So that means that you must evaluate the scan immediately. Now, our benchmark is that should happen within 45 minutes of the patient's arrival. The CT scan will help me determine if an intracranial hemorrhage is present. Now, if a hemorrhage is present, then our stroke team is going to pursue an entirely different path of treatment. On the other hand, If I find a normal CT scan, as in this case, that suggests an acute ischemic stroke is causing the patient's symptoms.
That brings us to the final limit in the stroke chain of survival. Rapid diagnosis and treatment in a hospital equipped for acute stroke patients. This is also the 6th D in stroke care, decision regarding treatment. In addition to IV fibrinolytics, endovascular therapy is recommended for large vessel occlusion, or LVO patients, who meet inclusion and time criteria. In some cases, endovascular procedures may not be available. An interfacility transfer should take place for those that meet the criteria for endovascular therapy.
With an ischemic stroke, CT scans often look normal within the first few hours of symptom onset. In this case, the CT scan looked normal and there was no evidence of bleeding. Thankfully, we were well within the window of fibrinolytic therapy. But before I recommended that treatment, I performed another neurologic exam and I asked some questions that were part of the fibrinolytic checklist. The neurologic exam showed no improvement. But before recommending fibrinolytic therapy, I wanted to review the patient's records and to see if there was any pre-existing conditions that might interfere with the drug treatment. These include brain hemorrhage, prior stroke, abnormal blood vessels in the brain, recent bleeding anywhere, any history of blood clotting problems, recent surgery or accidents, or certain prescription medications. I wasn't seeing any potential problems with the drug therapy. Nancy, what's her current BP?
It's 192 over 114.
Okay, the blood pressure's still a little bit high, so we're going to give you a drug to help bring that down. Okay, let's give her 10 milligrams of labetalol and try to get her systolic blood pressure down to 185 and then diastolic down to 110. Now we'll recheck in about 3 to 5 minutes. If it's still elevated, then we need to double it or consider an IV infusion. Just don't waste time.
Right away.
If the patient's medical history is acceptable, if the time of onset is generally less than 3 hours, and if the patient's current condition can be managed within suitable parameters, it's time to move to the next D of stroke care, drug and/or device.
Mrs. Vega, we'd like to recommend a medication to you that may break up the blood clot that's causing the stroke. But we'd like to talk to you about the potential risks of this medication so you can make an informed decision.
What kind of risks?
There is a small possibility of having a cerebral hemorrhage that's bleeding into the brain. Now, if this occurs, Mrs. Vega's situation could get worse or may even possibly be fatal.
It's only a very small risk, actually, about 5%.
That's right, but you still need to consider it. Now, the upside to this is the drug treatment may break up the blood clot in the brain, potentially restoring or improving blood flow to the affected areas, and that's a good thing.
Studies show that the drug therapy can improve the chances of recovery by 30% if administered within the first 3 hours of the symptom onset.
Now, the window can be extended for some select patients to 4.5 hours, but Mrs. Vega will easily make the 3-hour window, and that's even better. That never works for me. Sounds like it's worth the risk, right?
Okay. Nancy, based on her weight, let's administer our TPA according to our protocol.
Okay.
Okay, it's going to take us about an hour to give this medication to you through your IV.
I would do blood pressure and neuro checks every 15 minutes while she's taking the therapy. I'd also monitor her neurologic status.
Good. Looks like you're in good hands. I'll check back with you after the therapy.
After starting IV alteplase, the patient should be moved to the cath lab for endovascular therapy if they meet the criteria for large vessel occlusion. Patients who do not meet the time criteria for IV fibrinolytics may be candidates for endovascular therapy up to 24 hours after last known movement. For optimal recovery, hospital personnel must carefully control the patient's blood glucose levels, temperature, and blood pressure. The final D in the 8 Ds of stroke care is disposition. This means rapidly admitting the patient to a stroke unit or critical care unit.
Should be surrounded by a team of people who specialize in stroke. Statistics show that these specialty units provide best practices and not only increase her chances of survival, but really improve her outcome as well. With a little physical therapy and time on her side, she's likely to have a full recovery.
By rapidly recognizing the signs of acute stroke and preventing delay in diagnosis and treatment, you give the patient considerably higher chances for a full recovery.
Algorithms. Cardiac arrest algorithm. Here we go.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The cardiac arrest algorithm is the most important algorithm to know for adult resuscitation. This algorithm outlines the steps for pulseless patients who don't initially respond to BLS interventions, including a first shock from an AED or manual defibrillator. Because many patients with sudden cardiac arrest demonstrate VF at some point in their arrest, it's likely that ACLS providers will frequently follow the left side of the cardiac arrest algorithm, which we'll do here. After assessing the patient, the first and most crucial step is minimally interrupted high-quality CPR. The AHA recommends the use of audio and visual feedback devices to ensure that CPR quality is maintained and optimized during a resuscitation attempt. Treatment then branches into two pathways, one for shockable rhythms, which include VF and pulseless VT, and a pathway for non-shockable rhythms, asystole or PEA. For shockable rhythms, the first step is to deliver a shock as soon as a defibrillator becomes available. The appropriate energy dose is determined by the type of defibrillator, biphasic or monophasic, and the manufacturer's recommendations. After the shock, immediately resume CPR, beginning with chest compressions. If there are available rescuers, IV or IO access should be established. After 2 minutes, conduct a rhythm check. For persistent VF or pulseless VT, give another shock and resume CPR immediately. When IV or IO access is available, give 1 milligram of epinephrine during CPR after the second shock has been delivered. Repeat epinephrine administration every 3 to 5 minutes, or every 4 minutes as a mid-range, which corresponds to every other rhythm check. During resuscitation, epinephrine acts as a vasoconstrictor, which increases cerebral and coronary blood flow. Epinephrine does this by increasing mean arterial pressure and aortic diastolic pressure, which improves perfusion pressure to the brain and heart. After 2 minutes of CPR, conduct a rhythm check, being careful to minimize interruptions in chest compressions. If a rhythm check reveals a shockable rhythm, deliver another shock. Resume CPR, beginning with chest compressions, for 2 minutes immediately after the shock. At this point, you may consider giving amiodarone or lidocaine, antiarrhythmic agents that have been clinically demonstrated to improve the rate of ROSC and hospital admission in adults with refractory VF or pulseless VT. Amiodarone is a complex drug that affects sodium, potassium, and calcium channels. It has alpha-adrenergic and beta-adrenergic blocking properties, and it also blocks the action of hormones that speed up the heart rate. The overall effect is to slow the heart. Additionally, it lowers the defibrillation threshold, making defibrillation more effective at lower energy settings. Lidocaine depresses the automaticity of Purkinje fibers, raising the stimulation threshold in the ventricular muscle fibers, which makes the ventricles less likely to fibrillate. After administering amiodarone or lidocaine, check for a shockable rhythm at the 2-minute mark. If one is present, return to step 5 and work through the sequence again until ROSC is achieved, at which point you'll move on to the post-cardiac arrest care algorithm. If you are unable to achieve ROSC in a reasonable amount of time, consider the appropriateness of continuing resuscitation efforts. If you encounter non-shockable rhythms at step 4 or 6 and there are no signs of ROSC, go to step 10 or 11 on the asystole PEA pathway. The asystole PEA pathway is the option when the patient has a non-shockable rhythm after initial CPR. Give 1 milligram of epinephrine without interrupting CPR, repeated every 3 to 5 minutes, or every 4 minutes as a mid-range, which corresponds to every other rhythm check. If the rhythm after step 10 is shockable, go to step 5 or 7. If the rhythm is non-shockable, continue CPR for 2 more minutes and attempt to treat reversible causes if these have been determined. If there are no signs of ROSC, repeat steps 10 and 11. If ROSC is established, move on to post-cardiac arrest care algorithm. The cardiac arrest circular algorithm is another way of displaying the cardiac arrest algorithm. It summarizes the recommended sequence of actions after a cardiac arrest. It makes the point that not only is high-quality CPR performed continuously, but also CPR quality is monitored consistently.
I ain't lying, it's so boring.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The bradycardia algorithm outlines the steps for assessment and management of a patient presenting with symptomatic bradycardia with a pulse. Implementation of this algorithm begins with the identification of bradycardia, which is a heart rate less than 50 beats per minute.
Remember that
Once
number's
bradycardia has
changed.
been identified, first steps include the
50 now
components
less.
of the BLS assessment and primary assessment, such as supporting circulation and airway management, giving oxygen, monitoring.
It's not 60 anymore. Bradycardia is 50 or less.
And airway management, giving oxygen, monitoring the rhythm and vital signs, establishing IV access, and obtaining a 12-lead ECG if available. In addition, consider hypoxic and toxicologic causes. The primary decision point in the algorithm is determining whether the bradycardia is causing the patient's signs and symptoms or some other illness is causing the bradycardia. These symptoms include hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure. If the patient has adequate perfusion, observe and monitor. If the patient has poor perfusion, administer atropine. Classified as an anticholinergic drug, atropine is effective for the treatment of certain types of bradycardia. For example, if the vagus nerve stimulates the heart, the patient's heart rate will slow. Atropine blocks the action of the vagus nerve, causing the heart rate to increase. If atropine is ineffective, prepare for transcutaneous pacing and consider dopamine or epinephrine infusion. Transcutaneous pacing, or TCP, uses electrodes on the patient's chest to deliver an electrical impulse that overrides the normal pacemaker functions of the heart. In effect, TCP provides an external pacemaker signal. Dopamine stimulates the beta-1 adrenoceptors, resulting in improved myocardial contractility, increased sinoatrial node rate, and enhanced impulse conduction in the heart. If the patient doesn't respond to atropine, TCP, dopamine, or epinephrine, expert consultation. Prepare for transvenous pacing and search for and treat contributing causes, such as myocardial ischemia, drugs or toxins, hypoxia, or electrolyte imbalances. To determine the more challenging types of bradycardia, use the following tips for distinguishing the two types of second-degree AV blocks and third-degree AV block. For second-degree type 1 AV block, the PR interval will get progressively longer until a beat is dropped. For second-degree type 2 AV blocks, the PR interval will stay the same length, but random QRS complexes will be dropped. For third-degree AV block, the P wave and QRS complex will not have any relationship with each other. The P waves and QRS complexes are independently firing. In all three blocks, there are more P waves than QRS complexes. Bear in mind that the treatment sequence in the algorithm is determined by the severity of the patient's condition. You may need to implement multiple interventions simultaneously. If the patient goes into cardiac arrest, go to the cardiac arrest algorithm. Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The tachycardia algorithm simplifies initial management of tachycardia. The presence or absence of pulses is considered key to management of a patient with any tachycardia. If pulses are present, determine whether the patient is stable or unstable, and then provide treatment based on the patient's condition and rhythm. If a pulseless tachycardia is present, manage the patient according to the cardiac arrest algorithm. Implementation of this algorithm begins by verifying the presence of a pulse with the tachycardia. Most symptomatic tachyarrhythmias will present with a heart rate of 150 or more beats per minute. If a tachycardia and a pulse are present, maintain a patent airway and assist breathing as necessary. Provide oxygen if hypoxemic and monitor cardiac rhythm, blood pressure, and oxygen saturation. Obtain IV access and a 12-lead ECG if available. The tachycardia is unstable if the patient demonstrates rate-related cardiovascular compromise with signs and symptoms such as hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure. Immediate synchronized cardioversion is indicated. If time permits, establish IV access before cardioversion and administer sedation if the patient is conscious. However, don't delay cardioversion if the patient is extremely unstable. Synchronized cardioversion uses a sensor to deliver a shock synchronized with a peak of the QRS complex, the highest point of the R wave. Synchronization avoids the delivery of a shock during cardiac repolarization, a period of vulnerability in which a shock can precipitate VF. Refer to your specific device's recommended energy level to maximize first shock success. Check to make sure the synchronized marker is located on the R wave before clearing and cardioverting the patient.
If cardioversion is unsuccessful, consider the following. Underlying causes, the need to increase energy level for next cardioversion, the addition of antiarrhythmic drugs, and expert consultation.
On the other hand, if the patient is stable, the treatment path is determined by whether QRS is wide or narrow and whether the rhythm is regular or irregular. If a monomorphic wide complex rhythm is present and the patient is stable, expert consultation is advised because treatment has the potential for harm. The therapy for narrow QRS with regular rhythm is to attempt vagal maneuvers, and if unsuccessful, administer adenosine. Adenosine slows electrical conduction through the AV node and terminates approximately 90% of re-entry tachyarrhythmias within 2 minutes. Although it doesn't terminate atrial flutter or atrial fibrillation, it will slow AV conduction, allowing for identification of flutter or fibrillation waves, thereby allowing confirmation of the underlying tachyarrhythmia. If the rhythm converts with adenosine, it's most likely re-entry SVT. Observe for recurrence. Treat recurrence with adenosine or longer-acting AV nodal blocking agents, such as the non-dihydropyridine calcium channel blockers or beta blockers. Typically, you should obtain expert consultation if the tachycardia recurs. Adenosine should not be given for unstable or for irregular or polymorphic wide complex tachycardias because it may cause degeneration of the arrhythmia to VF.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The adult immediate post-cardiac arrest care algorithm begins with ROS. The first action is to ensure an adequate airway and support breathing immediately after ROS. Use the lowest inspired oxygen concentration that will maintain arterial oxyhemoglobin saturation between 92 and 98%. An unconscious or unresponsive patient will require an advanced airway for mechanical supported breathing if one is not already in place. Use continuous waveform capnography to confirm and monitor correct placement of the PT tube. Avoid ventilating the patient too quickly or with too much volume. Provide one ventilation every 6 seconds. Next, treat hypotension when systolic blood pressure is less than 90. When an IV is established, hypotension may be treated with an IV fluid bolus or various drug options. A hypotensive patient should be given a fluid bolus of normal saline or lactated wieners. Crystalloids, vasopressors such as epinephrine or norepinephrine, or an inotrope may be used. At this stage, consider treating any reversible causes that might have precipitated the cardiac arrest but persist after ROS. Obtain a 12-lead ECG as soon as possible to identify early those patients with STEMI or ECG evidence of the need for percutaneous pulmonary intervention. For patients with ECG evidence of STEMI or a high suspicion of AMI, attempt coronary reperfusion. ECG monitoring should continue after ROS, during transport, and throughout ICU care until deemed clinically unnecessary. If the patient does not have a STEMI and is hemodynamically unstable, consider coronary perfusion or mechanical circulatory support. Next, examine the patient's ability to follow verbal commands. If the patient fails to follow commands, the healthcare team should consider implementing targeted temperature management protocols and obtain a CT scan, EEG monitoring, and other critical care management protocols. After coronary reperfusion interventions, or in cases where the post-cardiac arrest patient has no ECG evidence or suspicion of MI, the healthcare team should attempt to determine etiology, obtain CT imaging considering pulmonary embolism, obtain laboratory analysis, and consider a drug screen. In addition, conduct an echocardiogram and transfer the patient to an intensive care unit. For additional information on each of the steps in the algorithms presented here, please consult the ACLS provider manual.
Huh? We are. Just a minute. All right, take a break, whiny ass. Huh?